इसमें भी आ रहा है, आपके पास भी आ रहा है साउंड? इसमें आ रहा है ना?
So we can go live now.
Yeah, yeah. Dr. Niharika, you rename yourself. Right में 3 dots है ना? Just put your name there.
Nitin, you can start the webinar.
Yes, ma'am. We are online.
Hello, and thank you all for joining us today. On behalf of Nari Division of Jackson Pal Pharma, we welcome you to the Journal Club today, up to date with updates, organized by the Haryana chapter of ISAR. From Nari Division, we present to you Cystelia M, formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women. Lycored M tablets of natural lycopene, fortified with N-acetylcysteine, enriched with CoQ10 and L-carnitine. For added advantage to win the race, Lycored M contains 2 proprietary complexes, natural lycopene as lycobeads from Israel, and L-carnitine and L-tartric acid in ratio 2:1 to give highest available L-carnitine as Carnipure sourced from Switzerland. A warm and hearty welcome to all the esteemed faculty and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. Please share it further for your friends to join. To refer to this webinar again in future, you can visit our YouTube channel, Jacksonpal Medical Insights. We now invite Dr. Jyoti Malik, Chairperson, Haryana Chapter of ISAR, and Director Roots IVF at JJ Institute of Medical Sciences, Bahadurgarh, to kindly initiate the program. Over to you, Jyoti ma'am.
Thank you so much, Dr. Deepika. Thank you, Jackson Paul and Dr. Deepika with your team. We bring to you this Up to Date with Updates, episode 10. This is the first episode of this year, but we have been continuing this for the last year. And with the team ISAR Haryana, with the secretary, Dr. Meenu Handa, with clinical secretary, Dr. Manju Dagar, and the treasurer, Dr. Lakshmi, I welcome you all on this platform. This is a very learning, interactive platform where we bring the latest journals where we can discuss the new studies, the new maybe the general reports. We deal with different sort of topics here, and we learn a lot on this platform with the think tanks of ISAR. This is actually a very big venture that has been supported by Dr. Amit Patki sir, who's our president ISAR, and our secretary, Dr. Asha Bakshi ma'am. So, and the other, do we have the CVs, Dr. Deepika? Yeah. So, we all know our president, sir, Dr. Amit Patki. He is Medical Director, Fertility Associates, Mumbai, and is the Honorary Associate Professor, Sumaya Medical College. He is also consultant to many hospitals at Khar Hinduja, Surya, and Khar Mumbai. And we have our secretary, Dr. Asha Bakshi ma'am. She is a lead consultant at Bakshi Fertility Center, and she has been the vice president 2022 of the West Zone of Foxy. Both with Dr. Patki sir and Dr. Asha Bakshi's ma'am support, and they're sort of always they are at the back of all our programs, and with the think tanks with our immediate past president, Dr. Nandita ma'am, President-elect Dr. Sunita Tendulkar ma'am, Vice President Dr. Madhuri Patil, Dr. Sujata Kar, and the chairman embryology and vice chairman embryology, Dr. Charuda Joshi, and Dr. Keshav Malhotra respectively. We do keep abreast with all these sort of activities. So thank you, our ISAR think tanks. And today we have another very special expert today, Dr. Surveen Ghuman, who is a thorough academician. She has been on this platform with us in the past as well. And to introduce her briefly, she is the Senior Director, Head IVF Reproductive Medicine, Max Group of multi-specialty hospitals. So many Maxes she is attached to: Panchsheel, Saket, Paparganj, BLK Delhi, and Gurugram. And she is also the Professor, School of Health Sciences, Ansal University. She has multiple academic positions in various societies and has 32 years of clinical experience, having authored 9 books and more than 80 publications, with running the program director for fellowship in reproductive medicine at Max Hospital. So thank you so much, Dr. Gurveen, because I'm leaving out your reading out the award part of it so that we can just save a little time. Yeah, and we have two very young presenters today. So our first presenter is Dr. Yukti Bhardwaj. She is consultant Indra IVF, Patel Nagar, New Delhi, and she is a fellow of the she's a FNB reproductive medicine from Sir Gangaram Hospital, has also done her diploma in ART for Germany, and she is currently the treasurer of Delhi Gynae Forum. She is a young, talented icon who has won Youth Icon Award, and she has been the star of Delhi ISAR, and she has also received ISAR Delhi Appreciation Award. Multiple prizes and multiple quizzes. Every time we hold a quiz, and if Dr. Yukti is there, we know she is going to stand first in that quiz. Without attending the quiz, we know that she is going to win that quiz. So she is a brilliant, brilliant person and brilliant keeping updates. So today I found that she is an apt person to update us with updates. So over to Dr. Yukti. Now I think I'll share a screen for you.
Thank you, ma'am. Thank you so much.
If you wish to do that, if you want to try and see it is working.
मैम कुछ टेक्निकल ग्लिच है तो
Okay.
मैम इफ यू
चलेगा. I'll
thank you so
share
much,
it.
ma'am.
Right. This one.
So thank you so much, Jyoti ma'am, for the kind introduction and giving me this opportunity. Good afternoon, Surveen ma'am. I feel extremely, it is an honor to be presenting in front of you. Thank you so much. So I will be starting my journal club. This next, ma'am, next slide, please.
Yeah, I'm just putting it on slideshow. Yeah. So, right.
So the topic of this journal club is limiting the number of fresh donor oocytes inseminated with sperm as a strategy to minimize the supernumerary embryos. This study was published by Samantha Spring et al. It was published in Fertility Sterility with impact for this journal. Fertility Sterility has an impact factor of 7.4. It has a high impact factor. And this this article was published in the year 2024 in December. So the objective of the objective of the study was to determine the optimal number of fresh donor oocytes to expose to sperm for patients who want to prioritize reducing the surplus embryos while preserving the live birth rate. And this was a cross-sectional study. Ma'am, next slide, please. Next slide, please. So the inclusion criteria for this study was the patients using fresh donor oocytes at Ronald O. Perelman and Claudia Cohen Center for Reproductive Medicine between January 2013 and November 2022. The patients who were excluded were the ones who did not use donor oocytes, who used fertilized frozen donor oocytes, used a directed oocyte donor, that is a self donor, or a donor age the donor age with age more than 32 years. Also, there were exclusions such as a couple who using surgically retrieved sperm who are undergoing PGT, using a gestational carrier or a surrogate, and who had an endometrial thickness less than 6 mm in their embryo transfer cycle. So this was their exclusion criteria. The primary outcome which was studied was the number of cryopreserved supernumerary blastocysts for a given number of fresh mature donor oocytes retrieved. So what are these supernumerary blastocysts? They are defined as the number of blastocysts remaining after the final cycle. And the final cycle is the cycle that resulted in the patient's first live birth, or if no live birth was achieved, the final cycle was the patient's last embryo transfer cycle at the institution. The secondary outcomes which were studied were the live birth rate for a given number of donor oocytes retrieved and the number of usable embryos. The number of usable embryos. Sorry, just a second. The number of usable embryos for a given number of donor oocytes retrieved. The usable embryo is any embryo that was transferred or cryopreserved as a blastocyst. So what was the donor ovarian stimulation like? The donors were started on OCPs, which was done for the follicular synchronization. A GnRH antagonist protocol was used for their stimulation. The ovulatory trigger was administered when at least 2 follicles were more than 17 mm. The trigger was either SCG, agonist trigger, or a dual trigger were used, and oocyte retrieval was done 35 hours after the trigger. ICSI was done on the day of retrieval and fertilization was determined on the next day. Usable embryos that did not undergo fresh embryo transfer were cryopreserved. Embryos were cryopreserved on day. Embryos were either cryopreserved on day 5 or 6 if the morphological grading by the Gardner criteria was 2 BB or higher. So this is the Gardner staging. And coming to the fresh embryo transfer and the donor synchronization. Ma'am, next slide, please. The donor oocyte recipients were synchronized to their respective oocyte donors' ovarian stimulation cycle using a leuprolide acetate and estrogen patches. The intramuscular progesterone was started the evening after the donor ovulation trigger. Estrogen patches and progesterone were titrated on the basis of their serum levels and continued till 10 to 12 weeks of gestation. Pregnancy was performed on cycle day 28 with the serum beta HCG, estradiol, and progesterone levels. So the frozen embryo transfer for all subsequent transfer cycles using cryopreserved embryos, frozen embryo transfer was performed in either a natural FET cycle or a program FET cycle. In the case of a natural FET cycle, monitoring was done from the mid-follicular phase with ultrasound monitoring of the follicle, endometrial thickness was measured, and the serial blood monitoring was done for luteinizing hormone, LH, estradiol, and progesterone. And the embryo transfer was done 5 days after the LS surge in case of natural cycle FET. Whereas for hormone replacement therapy FET cycle, estrogen patches were started on the day 2 of cycle and switched every other day for 2 weeks. So they were gradually titrated and increased. During this time, the serum estrogen levels and ultrasound monitoring was done to adjust the estrogen dosing according to the estradiol levels and the endometrial thickness. And once it was achieved, intramuscular, the oil-based preparation of progesterone was added, starting with a 25 milligram on day 1 and increased to 50 milligram for each subsequent day leading up to the transfer. And then the embryo transfer was done 6 days after the intramuscular progesterone. So now we will be discussing the results. So this table is showing the demographic characteristics for the fresh donor oocyte recipients. So this is the table for the recipients. So as you can see, thus the most of the recipients were above the age group of 42 years. That is, approximately 58% were above the age of 42 years. Most of them had they had a BMI between 18.5 to 24.9. They were of the white ethnicity. 70% belong to the white ethnicity, and since they were using a donor, approximately 98% them or 98% of them have had a diminished ovarian reserve. Yes, and since this is the next table, which is showing the embryo development and outcome stratified by the number of mature oocytes injected with sperm per individual. So as you can see, in most of the cases, in most of the donors, 8 to 10 mature oocytes were injected. Approximately in 180 patients, 8 to 10 mature oocytes were injected. And the other profile of the donor is the donor age at retrieval. Most of the donors were having an age of 26.5 years. Number of oocytes retrieved in these donors was 11. Number, as you can see in the below the 8, in the middle group, number of oocytes retrieved were 11. Number of mature oocytes were 9. Number of fertilized oocytes in this group was 7. Usable embryos were 4, and supernumerary blastocysts were 2. And we achieved, with approximately 8 to 10 mature oocytes, we achieved a live birth of 79%. And this live birth rate did not differ as the number of mature oocytes increased. So in the last, you can see the live birth rate remains almost the same even when the mature oocytes are increasing. But the number of supernumerary blastocysts is gradually increasing with the increasing number of mature oocytes. So coming to this bar diagram. So this is a bar diagram which is comparing the mature oocytes, fertilized oocytes, usable embryos, and supernumerary blastocysts. When less than 7 mature oocytes were used, 8 to 10 mature oocytes, 11 to 14, and more than 15 mature oocytes. So when less than 7, for example, if less than 7 mature oocytes, we had only one new supernumerary blastocyst, but it was gradually increasing as the number of mature oocytes. If for example, if it is more than 15, we had 6 supernumerary blastocysts. Next slide, please, ma'am. Thank you. This study evaluated patients using fresh donor oocyte to estimate the optimal number of donor oocytes that were needed to be injected with sperm to achieve a live birth, while minimizing the number of supernumerary blastocysts. It was demonstrated that fertilizing a higher number of fresh mature donor oocytes significantly increased the number of supernumerary blastocysts without an associated increase in the live birth rate. As we saw in that table, that the live birth rate remained almost the same. Yes, ma'am. Ma'am, next slide, please. The findings are consistent with the 2023 study by Korea et al., where they evaluated autologous oocytes in patients aged less than 32 years. Here they had, in Korea et al., they used autologous oocyte. The median number of oocytes to expose to sperm for one live birth was 7, according to them. This led them to conclude that 80% of cycles did not require exposing all oocytes to the sperm, and 7 oocytes were enough. And the present study expanded these findings to donor oocytes. They demonstrated that there was no apparent difference in live birth rate, whether 7, 8 to 10, 11 to 14, or 15 fresh donor oocytes were fertilized. There was, as I've already discussed, there was significant increase in supernumerary blastocysts as the number of oocytes exposed to some sperm increased. This study could help in approximating the number of fresh donor oocytes to fertilize for achieving the childbearing goals of the couple, while minimizing the surplus unused embryos. These surplus embryos pose a lot of logistic and financial burden on the families and clinic, since there are moral and religious objections regarding the disposition of cryopreserved embryos, whether that involves transferring embryos in the future, donating embryos to the couple, to other couples, or for research, or even discarding the embryo. The 2024 Alabama Supreme Court ruling equated cryopreserved embryos to unborn children, and potentially applying criminal charges for embryo destruction raises uncertainty about the legal status of embryos and future options for embryo disposition. So this the 2024 Alabama Supreme Court ruling have compared them to unborn children. So that is the importance of these embryos. Therefore, minimizing supernumerary embryos by limiting the number of oocytes exposed to sperm may become an important consideration for patients and the clinicians. Now, I'll be showing the strengths of the study. This study was performed at one institution and they had a standardized protocol for stimulation and embryo transfer. They used a single embryo lab for culture, fertilization, and storage of gametes and embryos. They had analyzed a large population of fresh donor oocyte recipients with a widespread of donor oocytes received. So they used a large sample size, though it was performed at a single institution. And what were the weaknesses? Since it is performed at a single institution, we cannot generalize it to all fertility clinics. This study is applicable to patients who only desire single live birth. And we cannot extrapolate these to the couples who require multiple children. So to conclude, the number of supernumerary blastocysts increased dramatically as more fresh mature donor oocytes were fertilized without an associated increase in the live birth rate. This data may help clinicians limit the number of fresh donor oocytes injected with sperm. The results are also valuable considering the future uncertainty surrounding the legal status of embryos and embryo disposition options. Thank you, ma'am. Thank you so much.
Thank you, Yukti. Very nicely presented. So, my question is that did they do a subgroup analysis on those who had a live birth and who didn't have a live birth? Because what we are concerned here is about patients who didn't have a live birth and they went in for a donor egg, right?
No, ma'am, they didn't do any such thing. Only till live birth rate they had done.
Yeah, they should have done a subgroup analysis of.
Yes, ma'am. That is one of the weakness of this study.
Taken oocytes, is it possible that had they taken 15, they may have had a live birth? You know?
Ma'am, according to this study, the live birth rate remains same, whether 7, 8 to 10, 14 or 15 were used, ma'am.
Yeah, the live birth remained the same in those who had a live birth. But what about those patients who didn't have a live birth? Did they have only 7 oocytes embryos to transfer, oocytes to transfer, or did they have more than that? You know, and then they underwent so that was a very important subgroup analysis which should have been done in this particular case.
Yes,
And
ma'am.
also in the inclusion criteria, there was a exclusion for the frozen transfers.
Fertilized frozen donor oocytes.
Now that they were only undergoing one embryo transfer, all these people, or was this a cumulative live birth rate? Because the second one will be a frozen, right?
Ma'am, this was a live birth rate for that particular transfer.
For the fresh transfer.
For the fresh transfer.
But then did they not undergo more live birth rate, more transfers? Did they stop the study there? They just did the first fresh transfer? Is that it?
Ma'am, I will one thing.
First fresh getting a success rate of 80%, that means.
So, ma'am, they had defined the supernumerary blastocysts as the number of blastocysts remaining after the final cycle. And the final cycle is defined that resulted in the patient's first live birth. Or if no live birth was achieved, final cycle, the last embryo transfer cycle at the institute.
You see in the exclusion, they have excluded the frozen, no?
Yes, ma'am. Yes, ma'am.
But they are using the frozen. So
they are
study
yes,
here. है ना?
Yes,
And the
ma'am.
other that they had in a natural cycle, they had done LH plus 5 days.
Normally, we are doing LH plus 7 in normally
Plus
that's
6.
what we
We
do.
are doing LH plus 6 and we are doing HCG plus 7.
If they had done progesterone monitoring, then I think with that it would have been better if we are doing with progesterone and then we are transferring after 5 days. But yes, ma'am, looks in the pre-receptive state.
Also, actually, all the donors were young, so there's no point in doing a age analysis on the donor. Otherwise, it would have been good to do an age analysis to see whether age was making a difference to the live birth rate here, and that whether an older donor would have required a higher number of supernumerary, higher number of embryos to be frozen to reach that live birth rate.
Ma'am, in the median age was around 26 and a half, and most of the donors were between 25 and 29 in this study.
And what about male factor? Did they remove male factor totally, or was male factor there?
They removed surgically sperm retrieved sperms.
What about
And
severe oats?
they did, ma'am, they have not mentioned about that, I think.
So that again, maybe if they had done a subgroup analysis of a severe oats, they may have found that yes, they require 15 embryos.
Yes,
15
ma'am,
eggs.
if the male
So
factor is
ideally,
there.
this study does require a subgroup analysis. You can't make a blanket this thing, because all of us, when we are doing a donor cycle with severe oats, we are always wanting more embryos because we
More
know that
embryos.
ultimately we're not going to get a pregnancy unless we do a couple of transfers, right?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
That was one more thing which I felt. But what do you feel about the study? How does it help us in our practice? Because this one donor oocytes can only, according to our law, can only be used for one patient. So should we be saving oocytes and
Ma'am,
not fertilizing?
it can help us in optimizing our stimulation protocol for donors, that we don't have to aim at a higher oocyte number in case of donor, as the ART law suggests that we should have a oocyte number of 7 in donors.
Yeah.
So this can prevent hyperstimulation and maybe OHSS in these donors.
Yeah, but
And we know
provided,
that
I feel that the subgroups are all clear. The subgroups here are not that clear. The male factor infertility is a huge subgroup. I would also
Yes.
put subgroups as endometriosis, because again, there the implantation rate is hampered. So I would like to analyze women with endometriosis and without endometriosis, whether they fared the same way or they didn't fare the same way.
Ma'am, I was just looking at the table, ma'am. Only 13% in this study had a male factor, 13%. Most of them were with diminished ovarian reserve, and
Yeah, but
13%.
those could have been the ones which didn't have a live birth.
Yes,
So
ma'am.
in them, definitely we would like more oocytes so that it gives us
Yes,
a
ma'am.
better chance. है ना?
Better embryos.
Similarly, if you look at endometriosis, again, they should have done a subgroup analysis of the cause of infertility for women. That also makes a big difference, because endometriosis is known to have a lower implantation rate.
Yes, ma'am. Endometriosis. Yes, ma'am.
Adenomyosis again is known to have, the endometrium might be growing well, but if she has adenomyotic uterus, again, that is a confounding factor in the study.
So approximately, ma'am, 9% of them had endometriosis, and 7% had a uterine factor. Like most of them, the women, yes, ma'am, 9.9% had endometriosis and 7% had uterine factor. But most of
So it
them were
would be,
just with plain diminished ovarian reserve.
in fact, it would be good to analyze what was the unexplained infertility success rate, because that tells us that this segment probably would fare well with just 7 oocytes.
Yes, ma'am. Yes, ma'am.
Dr. Survi, now what do they do with the supernumerary oocytes? Means they freeze those oocytes. And
No, see,
because they say
they
that
freeze
the
it.
law, their law says that, okay, embryo is a human being or whatever, and there are ethical issues involved, and therefore we should not be having supernumerary embryos. So if, let's say, if
Yeah.
we have 10 oocytes and if we make, if we want to have only one blast, so what do we, I mean, do we fertilize only 7 oocytes so in a, so as to get one blast, or what do, I mean, I really, I mean, you
So
please
that's what
explain
I'm
it.
saying, that this is a whole different this thing. There should be a subgroup analysis. Like if you have a male factor, severe male factor, I would
Hmm.
like as many as possible to fertilize, because I don't know what
Yeah.
the outcome is going to be. Even
Mhm.
in, let's say, endometriosis, I would like that, adenomyosis, I would like. So there, what they do is they save the oocytes for another patient. They have oocyte banks.
Okay. Okay.
So oocyte banks they use for others, but we cannot use it for others. So I
Right.
actually feel that in our scenario, even if they are supernumerary embryos lying, she'll use it for a second child. Na? At least
Yes.
if we genetically connected the two children. That's
Yeah.
how I advise my patients, that keep them and use it for a second child.
Right. No, we can keep them for maybe 2 years, 3 years. Whenever they plan, we have the frozen embryos
Yeah.
ready with us. And then she doesn't have to again look for another donor. It saves money as well.
Saves money, the two children are genetically connected.
Connected, right?
So I always
Yes.
advise the patients to keep them frozen, and many patients do, and they come back for another transfer.
Hmm. Yeah. Yeah.
Ma'am, I
So let
always
me.
used to think where this magical number of 7 is coming for
Ah.
in donors. Now I'm able, while studying for this dental club, then I could understand.
Yeah.
You think the government people went and saw whether 7 was there or not? I
No,
don't think so.
they did not go through this paper. This is a very recent paper, December 2024.
Yeah.
So our
Yes, ma'am.
law
Yes,
came
ma'am.
2 years back.
Yes, ma'am.
Our has already come
Yes, yes,
three,
yes.
not 2 years, maybe more, 3 years now.
Oh, 3 years now. 3 years.
Yeah. So Dr. Anita Rajoria is saying good presentation. I'm sure she must be happy seeing you presenting, Dr. Yukti. So now I think we go. Can I invite Dr. Meenu to please invite our next speaker? And so that because 5 o'clock we have to wind up that way.
Well done,
Thank you.
Yukti. Very
Thank
nice
you.
Thank you
presentation.
so much. Thank you, ma'am. Thank you.
We now move on to our the second talk, and the speaker for the talk is Dr. Can I have the CV? Dr. Niharika Sharma. She's a senior consultant at Accord Offspring Fertility and IVF Center at Faridabad. And she's done her fellowship in ART and fetal medicine from St. Stephen's Hospital, Delhi. And she's been the former associate consultant at BLK Max. And she's also the former senior consultant at Neelkant IVF Center. Over to you, Dr. Niharika, for your presentation.
Hi, Meenu.
Hi, Dr. Serene. Dr. Niharika, are you
Yes,
able
ma'am.
to share?
Yes, ma'am. Yeah, yes, ma'am.
Yeah.
Sharing it. Ma'am, my screen is visible? Hello,
Yes,
ma'am.
Yeah,
yes,
it
Dr.
is.
Niharika, you can start.
Yeah. First of all, ma'am, thanks a lot, Dr. Jyoti, Dr. Surveen, ma'am. It's great pleasure to come on this platform again. And now I am going to present my journal club on the topic, which is pre-implantation genetic testing for aneuploidy in cases of unexplained RPL. This was a systemic review and meta-analysis, and it was published in Fertile Sterile, just latest edition, January 2025, by Shagjan et al. As we all know that basically recurrent pregnancy loss, we say more than 3 consecutive or non-consecutive pregnancy losses. But the recent ASHRAE and ASRM guidelines suggest that now we take a RPL as more than or equal to 2 consecutive or non-consecutive pregnancy losses, which also encompassing biochemical pregnancies and pregnancies of unknown location. So as soon as we take the definition of more than or equal to 2 consecutive losses, the prevalence itself increases from 0.1 to 1% to 2 to 3%. And among all the cases of recurrent pregnancy loss, almost 50% of the cases remain unexplained, in which we have no reason. So, if we do the comprehensive chromosomal analysis of products of conception, that indicates that aneuploidy rates are almost comparable in natural ART and RPL pregnancies. And if we do the RPL workup of these patients, RPL patient, so more than 90% of the patient has a chromosomal abnormality in products of conception, which highlights the relevance of comprehensive chromosomal analysis and rate of aneuploidy in these type of patients. So ART, if we do with PGT-A, it helps in deselecting aneuploid embryos, which thereby enhances the clinical pregnancy rates and the pregnancy losses. But there are only few studies which are available to investigate the use of PGT-A in RPL, and no guidelines or recommendation are available in this. So this meta-analysis was done to answer the following questions. First, what is the likelihood of live birth rate in subsequent pregnancies in these patients? The rate of aneuploidy, blastocyst in unexplained recurrent pregnancy loss, whether the euploid blastocyst offer the similar live birth in unexplained RPL, whether endometrium is less selective, and finally, if we do PGT-A in these patients, whether it will increase the live birth or limit pregnancy losses until delivery. So now coming to material and methods, this systemic review was conducted following the preferred reporting items for systemic reviews and meta-analysis guidelines. So literature was published in PubMed and Cochrane databases, and they take all the articles right from the inception to the March 2024 articles. The study selection was all the studies that involved patients with RPL who underwent ART with PGT-A, ART without PGT-A, or expected management. PGT-A was done by trophoectoderm biopsy, and CCA only were included. Only the original articles and abstracts in English were included. The data was extracted as by first investigator last name, year of publication, country of study, study design, number of participants, clinical pregnancy rates per ET, live birth rate per ET. And ma'am, I'm not able to see. Actually, my picture is coming in the last line.
Specific remarks of the studies.
Yeah.
The last line is limitation and specific remark of the study.
Okay. The outcome measures and synthesis of results were done. So the primary outcome they taken as live birth rate per embryo transfer and per patient. The secondary outcome was clinical pregnancy rates and clinical pregnancy loss rates. The statistics was done using Mantel-Hans's odds ratio with 95 confidence interval. Random effect module was used, and assessment of statistically heterogeneity was done using forest plots and I-square statistics. So the results were, they found 118 eligible publications they searched, but only the relevant study was found in only the 19 studies. So they divided further these 19 studies into two groups. First, 8 studies, they were which compare the reproductive outcome in patients with unexplained RPL and non-RPL patient, both undergoing ART with PGT-A. Means they compared RPL group versus fertile population. Second comparison was done in 11 studies they found, which compared reproductive outcomes in patients with RPL with undergoing ART with PGT-A versus ART without PGT-A. So 11 studies took only the RPL patients. So now, first of all, coming to two main questions, whether there is any, what are the expectation of, what are the chances of live birth in unexplained RPL group, that is if they conceive spontaneously. So this was not the part of this study, but it was data found that it was a study which done in Norway, and they included almost 21,000 pregnancy losses between 2009 and 2013. And effect of maternal age on the pregnancy loss was adjusted. So the inference was, as the number of pregnancy losses increases, the rate of pregnancy, prior pregnancy losses increases, the rate of pregnancy loss in that respective pregnancy increases. So if the patient is conceiving for the first time, there is almost 11% chance that she get this pregnancy loss. If she has one prior pregnancy loss, 19% chance is there that she can have pregnancy loss in this pregnancy. So if the patient is having prior 3 pregnancy losses, almost there is 40% chance of again going into miscarriage, and the odds ratio also increases. So as the number of prior pregnancy loss increases, the chances of getting the live birth rate subsequently decreases. Second most important question which come in our mind is, do unexplained recurrent pregnancy loss have a high aneuploidy rate? So they found 6 randomized control trial which compared blastocyst aneuploidy rates. 2 RCTs among these 6, they reported higher aneuploidy rate, while 4 reported comparable rate. Amongst these 2 were, first of all, the study was Port et al. He compared between recurrent pregnancy loss patient PGTA versus non-recurrent pregnancy loss PGTA, means fertile group. And aneuploidy rates were significantly higher in RPL group than in fertile group who underwent PGTA for sex selection. But the indication for PGTA was the sex selection. However, in this study, the RPL group were older. RPL group average age was 37 as compared to 34 in non-RPL group. Second study which showed the higher aneuploidy rates in RPL group was done by Liu et al., which was published in Fertile Sterility 2020, and they compared between RPL PGTA versus PGTA due to single gene defects. And they found that they divide into 2 groups, less than 35 and more than 35. But they found less than 35 years, aneuploidy rates were higher in unexplained group, but the comparable aneuploidy rates were found if the patient's age was more than 35 in both the age group. Among the 4 studies, the 2 studies which showed the comparable aneuploidy rates in cases of RPL. First of all was Turgut et al. They compared euploidy rates according to the previous pregnancy losses, and all the patients were less than 35 years. So if we say that aneuploidy rates increases as the patient age increases, that factor has been diminished in this. And they found that comparable euploidy rates were found in all the cases of recurrent pregnancy loss, and it's not related to the number of prior pregnancy losses. Simultaneously, another study, Simedon et al. was done. They took all the OPU cycles irrespective of the age, everything, recurrent prior pregnancy loss, all OPU cycle he took with blastocyst, and that finally have undergone PGTA. Then they divided the patient into groups based on their age, and then further categorized according to their pregnancy losses. So what they found that similar euploidy rates were found in each group for the number of previous pregnancy loss categories. So now coming to so we have seen, first of all, the incidence of live birth in unexplained pregnancy loss. Second is the euploidy rates are higher in RPL groups. These 2 questions we have seen. Now coming to the main motto of this study. So first of all, they compared the 8 study which I have taken. So they make the 2 RPL group and non-RPL group, and both these groups, they have undergone the PGTA. So they compared their clinical pregnancy rate, clinical pregnancy loss rate, and live birth rate. So coming to the euploid blastocyst transfer in patients of RPL PGTA versus non-RPL PGTA. So if we see this chart, they have almost taken 7 studies, and the if the all the blue things are coming lower in the RPL, and the odds ratio is near 0.9, so it is not very significant. So we can say that they have similar clinical pregnancy rates in both the groups, whether it is RPL or non-RPL. If we do the PGTA in both the groups. Now coming to the rate of clinical pregnancy loss in both the groups, RPL versus non-RPL. So it was numerically higher, but statistically similar clinical pregnancy loss rates were found, as the odds ratio was 1.4%, which is not very, very significant. But numerically it was showing to the higher in the RPL, but statistically they have suggested that it is not more than, if they take the odds ratio more than 2, then according to them it is going to be more significance, near about 1 to 1.5. They take it as a non-significant group. So they have suggested that it is, although it is coming to higher in the RPL group, blue marks, but still the odds ratio is 1 to 1.5. So we can take it similar clinical pregnancy loss rates. Now coming to live birth rate. In this, they have taken all the 7 studies, and they have suggested that clinical suggesting of the low live birth rate. But again, it is of low quality evidence. So amongst these studies, they have selected 3 studies which was good quality. And the good quality studies was, amongst these, Wong et al., Simadon D et al., and Confield et al. And these good quality studies, they have again statistically studied, which showed similar rates. So we can say that also in live birth rate, similar live birth rate were observed in women with RPL as compared to those without RPL. So we can suggest that if we do the euploid blastocyst transfer in RPL with PGTA versus non-RPL with PGTA, they have similar clinical pregnancy rates, statistically similar clinical pregnancy loss rates, and low birth rate. But if they take good quality study, then again the live birth rate is comparable. So we can say that it is similar live birth rate. Now coming to another comparison of which they took 11 studies, and they took only RPL patients. So they made two groups. They made two groups, RPL with PGTA versus RPL without PGTA. So again, they make the inference based on the clinical pregnancy loss rates, and the live birth rate. So coming to the clinical pregnancy rate, as compared to those without PGTA, patients who undergone ART with PGTA had higher clinical pregnancy rates with odds ratio of 1.76, but again the evidence of quality was significantly low. As in coming to clinical pregnancy loss rates, they found that lower clinical pregnancy rates were found in cases of RPL who undergone PGTA versus who did not undergo PGTA. RPL versus and higher birth rate was also found in RPL group with PGTA group versus non-PGTA group. So overall, we can suggest that patients with unexplained RPL, PGTA could increase live birth rate per transfer and per patients, decrease clinical pregnancy loss rates, but because the chance of expectant management, if we leave these patients to conceive spontaneously, still there is approximately 60 to 70% of chance that they conceive. So sufficiently powered RCTs is required, which compare the PGTA versus expectant management for RPL. So coming to discussion, these findings suggest that unexplained RPL have a decent chance of live birth with expectant management, though the risk of subsequent pregnancy loss increases with number of pregnancy losses. Studies comparing euploidy rates between women with and without RPL yielded contradictory results. Two RCTs, Kohn et al. And Liu et al. Suggested more aneuploidy rates and four were showing the comparables results. Study about Cott et al. Can be questioned as patients with RPL were significantly older, and whether such a strong confounder as age can be adequately adjusted for by a regression model, or a 2.5-year difference would lead to an approximately 30% increase in aneuploidy rates is debatable. And study was Liu et al., as I already said, has a limited sample size and reported unadjusted analysis. Overall, available evidence favors similar euploidy rates between RPL and non-RPL patients, but again, high-quality large prospective studies are needed. Comparators should be similar for other factors that can also affect aneuploidy rates and pregnancy loss rates, such as female age. But if the answer is affirmative, PGTA might offer a potential solution for unexplained RPL group. More than half of the pregnancy losses, including women with RPL, are attributed to numerical chromosomal errors, with trisomy being the most common, followed by polyploidy and monosomy X. These aneuploidy pregnancy losses occur randomly, implying the risk of subsequent pregnancy losses would not be increased. In contrast, euploidy pregnancy loss rates increases in parallel with the number of previous pregnancy losses, as we have seen, whereas sporadic aneuploidy remain constant. As most pregnancy losses are due to aneuploidy, PGTA can be expected to decrease their incidence. So, PGTA with 24 chromosome analysis offers advantages in general ART population. This includes single embryo transfer, irrespective of female age and number of previous ART attempts, thereby enhancing live birth rates and reducing pregnancy loss rates. But this strategy, if we do PGTA in all the cases, so these offers the potential drawbacks also, as first, risk of misdiagnosis that depends on the genetic lab. Embryo damage may be there, infected by biopsy, and it can offer an increased cost also. So moreover, PGTA does not necessarily improve cumulative delivery rates per aspiration cycle in the general ART population. So, awaiting more robust study, the current evidence provides insight about patient population who may benefit from PGTA for unexplained RPL. These patients are patients with adequate ovarian reserve testing who are already undergoing IVF. The observed trend toward lower pregnancy rate, loss rate with PGTA suggests that in long term it decreases the number of previous pregnancy losses until a live birth is achieved in such cases. Second patients will be patients with advanced maternal age who have high incidence of aneuploidy due to their age. Third, patient with history of previous aneuploidy losses if we have done CCA in their POCs. And fourth is coexistence of other indications. So Z et al., they conducted a novel study which was non-invasive chromosomal screening NICS by DNA culture in media versus non-NICS by blastocyst morphology. He studied 173 RPL patients with ART with NICS versus 84 patients with ART without NICS, just by doing the blastocyst morphology. So in the NICS group, 113 FET cycle were taken, and non-NICS group, 136 blasts were transferred to 80 patients. So what he found was, in the NICS group, where they have done the DNA analysis in the culture media, they have high ongoing pregnancy rates, high live birth rate, and lower pregnancy loss rate per FET cycle. So this is like mini PGTA. We are just not touching the embryo, but we are taking the DNA from the culture media. And artificial models, intelligence models are also underway on the basis of morphokinetic characteristics as non-invasive embryo selection tools. So, coming to conclusion, despite some data suggest similar aneuploidy rates in unexplained RPL, uncertainty remains because of low quality evidence. Transfer of euploid embryo like blastocyst likely yields comparable live birth rates in unexplained RPL as well as in non-RPL patients. PGTA could increase the live birth rate per ET and per patient while reducing the clinical pregnancy loss rates in patients with unexplained RPL. It may not be offered to every patient, but arguably patients with adequate ovarian reserve benefits from ART-PGTA as it increases the number of gametes available and reducing the time to live birth. And it also is beneficial in advanced age patients who have high incidence of aneuploidy embryos and can be considered for suitable and secondly, they are considered suitable candidates also to avoid repeated risk of repeated aneuploidy pregnancy loss. Second, subsequently, they may have a chances of developing infertility because of age-related ovarian reserve decline. But the ASRM and ASHRAE do not recommend PGTA for the unexplained RPL. What is the reason? The reason is these patients are not infertile and do not need ART in the first place and absence of direct benefit of PGTA. As unexplained RPL is multifaceted distressing condition, it seems unlikely that conclusive RCTs comparing PGTA versus expected management will be available soon. And CCA of POCs is also not recommended, but can be considered to provide a patient with an explanation, and PGTA will remain a choice on an individual basis. Thank you, ma'am.
Thank you, Niharika. You chose a very good study to discuss. I just want to know that how many RCTs were included in this study, randomized controlled trials?
Ma'am, they have taken 19 RCTs, 19 studies they had taken.
No, for the section of recurrent pregnancy loss, where we did PGTA, and recurrent pregnancy loss, where we didn't do PGTA.
In the RPL group only, ma'am?
Yes, in the RPL group.
This is the RPL group, ma'am. They have taken, I think, 8. No. It's 1, 2, 11. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 studies they have taken.
You know what? You need to go into each study. So there is a table in this study, in this meta-analysis, which shows you how many studies are RCTs. There is only one RCT of Sui et al. And that's a very small sample size. It's not very big.
Yes, ma'am.
There is one prospective study of Sato, and that is all. The rest are all retrospective.
Yes,
and if you see this big square here on your chart,
yes, ma'am.
that comes from Bhatt et al. Okay, that is the one which has actually changed the whole scenario. And this Bhatt et al. Study of 2,500 patients, a total of 4,200, sorry, in each group, is just SART data. It is only analysis of SART data. So whenever you look at a meta-analysis, the first thing you have to see is what is the study which has come. Is it a RCT? Because retrospective studies are actually considered to be very, very low level evidence, out of which we do not take out any kind of recommendations. So when we look at this, we actually are not looking at 8, 9 studies. We are looking at a study of Bhatt et al., which is just data sent from all IVF centers randomly.
The number of patients are very high. It's
Very high. And that is what
2,500.
skewed
Yes.
this whole result. Also,
Yes, ma'am.
they have not, put together how many patients were eliminated because they didn't form enough blasts for a biopsy. Now,
No, ma'am, these all patients had undergone the PGTA.
yes, all these patients had undergone a PGTA, but there were also patients who could not undergo a PGTA. So that must be mentioned that after
Due to
all,
any reason, yes.
inclusion criteria, right? If there was
Yes,
no
ma'am.
inclusion of those patients, they were included in the study, but somewhere down the line, they got excluded.
Initially, they have decided that they will take that for PGTA, but for some reason they couldn't took that patient. Yes,
They
ma'am.
couldn't take it because probably it was a beyond BB blast.
Blast or something, yeah.
But that patient has to be accountable somewhere when you do the stat analysis, no?
Yes, ma'am.
That is very important. And another thing which this thing did not comment on this meta-analysis was biases. They have made no comment on biases, and it is so important to make a comment on biases, whether it is publication bias or it is, inclusion bias or exclusion bias, whatever it is, the biases have to be put.
But bias will be, I think it will appear in prospective studies, not in retrospective, because this is totally blind one. If we do analysis the data of retrospective, it is totally blind. We did not do,
Have one RCT.
yeah,
And
RCTs.
in the first group, which was euploidy rates in both, there are RCTs. But they did not analyze biases as far as these were concerned. And they did not do a subgroup analysis. Some studies have done, but many have not done a subgroup analysis of age.
Yes, ma'am. Age, so they have not taken in any of these. Only the,
Very
yeah,
important.
yeah.
When you're looking at euploidy rates, if one section has a higher age group, your
Exactly.
data immediately gets skewed. No? It is immediately skewed. So those are my comments. I don't think we can actually take out a definitive conclusion till we have RCTs in this. Otherwise, you've gone over the data very well, but the most important thing was to look at what type of study it is, which is when we made the guidelines, there were so many meta-analysis, and we realized that these meta-analysis actually are just putting together studies which are non-relevant.
But ma'am, mostly when patients now come, so how do we approach them? Should we offer? That's what we are discussing
We should
actually.
offer because it gives an explanation. So and it also decreases the number of embryo transfers we are doing. Each time we do an embryo transfer, there is so much stress.
Yeah. Yes,
So
ma'am.
if you have a tested embryo, at least you're doing half the number of embryo transfers if you say 50% euploidy rate. Hai. So that is one stress which is decreased. But like they said, recurrent pregnancy loss, they have equal number of euploid blasts. So should we take them for IVF and PGTA? That is a big query. It is a big query, and both ASRM and ASHRAE have said that we should not. So, but yes, if we are doing an IVF and she is a recurrent pregnancy loss, then we should offer a euploid.
If we are doing IVF in recurrent, then we should offer. But
yes, if you are doing an IVF and she's a recurrent pregnancy loss, whether it was a natural pregnancy or an IVF pregnancy, since we are doing the IVF, we should go ahead and do a PGTA.
PGTA.
And we should not do an IVF for recurrent pregnancy loss to do a PGTA, because that has not been found to be very useful.
Exactly. And do we start doing CC chromosome analysis of every patient who is miscarrying in previous pregnancy losses patient, RPL patient? Should we offer?
For the parents?
Considering
For the
that,
parents,
yeah.
you're saying? Yes,
Yes.
I think you should do it. Because many times now something comes out in that. And when something comes out, then your PGTA gets automatically, or a PGTM may be required. You don't know what comes out. So if she's had 3 losses, then you should. For parents, you should.
Okay, ma'am. Thank you,
I
ma'am.
offer a whole exome sequencing. I don't even say do karyotyping.
Yes,
these days
ma'am.
tell them, please
Chromosome
go for whole
microarray is
exome
the,
sequencing, because you'll do the karyotype, but we get half the information. What's the point? It's better to just spend and go in for whole exome sequencing.
And it leads to maternal contamination also. If we do the simple karyotype, many of times it gets contaminated also. So it's better if we do the whole exome sequencing or microarray testing. That is the thing. Okay, ma'am.
Yeah. So that was a wonderful discussion. Very nice. We could understand, Dr. Surveen, from your discussion that the study has to be it has to be a RCT or a prospective study.
Or a prospective study.
Yeah. And
retrospective is the lowest cohort. Retrospective is the lowest which we would take. So a good meta-analysis is of the highest score. Next score comes a meta-analysis with not that good methodology, but of course having RCTs, along with a randomized control trial of good methodology. That's a B score. A C score is randomized controlled trial of query methodology, not very good methodology, and a observational study with a good methodology. And the lowest is retrospective study with a poor methodology.
And can you make a slide, because we couldn't get enough this thing. I couldn't note first.
I'll just put it forward, because yesterday only I presented at ISAR.
I was there. Yes, ma'am.
So 1 second. Can I screen share?
Yes, ma'am.
You stop, Niharika, you stop your
ma'am.
screen share.
Okay, ma'am. Okay, ma'am. Doing.
So let me first open it, I think. We have time.
Yeah, we have another 1 to 2 minutes more, if Dr. Deepika allows us.
So you
Another
can
5 10
see
minutes.
this. You can see
Yeah.
this?
Yes, yes, yes.
Okay.
Dr. Surveen, can you present this in your next in our next journal club?
Yeah,
These
I have the
guidelines?
complete methodology, but I'm just going to the slide which she wants.
Yeah. No,
And
no. I request you to. I mean, we will not take another fertility sterility journal, but we'll take your this talk on guidelines on POR in our
sure,
next
sure.
club.
So this is it. See, you can take a
Ah,
picture of
Yes, ma'am.
this.
I'm taking that. Yeah.
So high is recommendations of high quality meta-analysis, including well-designed RCTs. Moderate is good quality RCTs and meta-analysis with multiple RCTs with some potential of methodology. So RCTs have to be there even in the moderate quality. Remember, when you're doing a meta-analysis, RCTs have to be there. Low is RCTs with some methodological concern. Maybe they haven't done a bias study, high quality cohort studies. And very low is cohort studies with methodological concerns, case control, and other study designs. So this is how you grade your quality of evidence. So I would put yours probably as very low or maybe low. I would not put it as high or moderate because your meta-analysis never had any RCTs except one small one. So that is how. So I can, Jyoti, I can do it anytime you want. I'll present.
yeah. Next month.
Yeah.
It would be fourth
It's on
Wednesday of
February 26th, ma'am.
26th Feb.
Yeah, I'm here. I can do it.
So
Ma'am.
26th Feb, one of this
Just,
your guidelines on POR.
just send me a message एक बारी ना,
Yes,
then I'll.
yes, definitely. We will do that. That would be good.
Surveen,
Great.
ma'am?
हाँ जी.
हाँ मैम, ये जो this systematic review that also comes in high, ma'am. Systematic reviews.
Systematic review and meta-analysis. It has to be a meta-analysis because meta-analysis gets you the number and the forest plot. A systematic review can be a review of literature only. That is just a review of literature. So that may not have numbers. But a meta-analysis will always have your forest plots.
Thank you, ma'am. Thank you so much.
Right. So thank you each one. Thank you, Dr. Surveen, for those very,
Thank you
very.
for following me here, and Isar, Amit, Asha, all of you. Thank you.
Thank you
And
so much.
and Meenu.
Yes. And thank you, our presenters, Dr. Yukti and Dr. Niharika. It was great. Your presentations were very good, and we could understand, I mean, how many oocytes we should be, how many blasts we should be sort of taking, and also about this RPL, PGT, and all. So both the presentations were very good. The discussion was great. And though we have few participants, but I think if we have more than 10 participants here on this platform, those are people who are really wanting to understand the depth of all these presentations. Thank you, Dr. Deepika, and thank you, Jackson Paul, for your time and giving us this platform. Thank you, each one.
Thank you, ma'am.
Thank you, ma'am, for the opportunity, ma'am. Thank you.
Thank you so much.
Thank you so much for your support to Cystilia M to restore the ovulation and reproductive health of women. Cystilia M is formulated with the ideal ratio of 40:1 myo-inositol and D-chiroinositol. Looking forward to your support. Also, the other brand that we had mentioned, Lycored M for male infertility. These Lycored M tablets of natural lycopene are fortified with N-acetylcysteine, enriched with CoQ10 and L-carnitine. And Lycored M contains two proprietary complexes, lycobeads from Israel, that is natural lycopene, and Carni Pure sourced from Switzerland, which contains L-carnitine and L-tartaric acid in ratio of 2:1 to give the highest available L-carnitine. So thank you so very much, and we look forward to the next up-to-dates on 26th of Feb next month.
Thank you.
Right. Thank you. Thank you. Bye-bye. See you.
today class खत्म
Nitin, we can close the meeting now. Nitin, we can close the meeting now.
Okay, ma'am.